Good evening, everyone. Welcome to tonight's GP education event, GP physio education event on the shoulder. I'm Dr. Andrew Rotstein from Victoria House Medical Imaging, and tonight is part of the Victoria House 30-year anniversary celebrations. We began in 1989 and we've moved here a year and a half ago. So tonight we're doing shoulder, and then we have ankle and foot in September, and we have knee in October. And we're also partnering with Life Care Paran, who are upstairs, and we're very honoured to have sports physician Dr. Stuart Down here, as well as Mr. Austin Vo and Nick Meffin, physiotherapists. So I'm going to just read out the biographies of our panellists as well. So Stuart Down was from Monash University. He finished with honours in 1998. He's a sports physician with a diploma in sports medicine from the AIS in 2005, and he's a fellowship of the Australian College of Sports Physicians, which he achieved in 2008, and he got the college medal for the highest ranked graduate. He currently provides medical care for Cricket Victoria, and he has done so since 2006, supporting the Melbourne Renegades. He was also part of the Commonwealth Games. Stuart's very interested in acute injuries of knee, ankle, shoulder and wrist, and has a strong interest in hip pathologies as well as stress fractures as well, and other musculoskeletal conditions and other conditions in adolescence. Okay, Mr. Austin Vo is a highly qualified Melbourne-trained orthopaedic surgeon with expertise in all aspects of shoulder and knee surgery. His international subspecialty training occurred at world-renowned centres including Oxford, France and Canada, and he is able to use the latest arthroscopic and minimally invasive surgical techniques to treat common conditions such as rotator cuff tears and shoulder instability. Austin also consults upstairs at Life Care Paran, in addition to his main rooms near St Vincent's Private Hospital in East Melbourne, and is part of the MSK, or Melbourne Shoulder and Knee Group. He's actively involved in teaching orthopaedic surgeons with public appointments at Austin and Monash Health. Nick Meffin is a director of Life Care Physiotherapy Paran upstairs. He trained in Auckland, New Zealand, and we won't hold that against him. He has a Master's in Sports and Exercise Physiotherapy from La Trobe University. Nick has a very hands-on approach in combining exercise-based medicine physiotherapy treatments as well as shockwave therapy, dry needling, manipulation and soft tissue mobilisation. He also provides support to Cricket Victoria, Cricket New Zealand, and currently is working with the Kilsyth Cobras in the NBL 1. Now, we're also very privileged tonight to have Dr. Danny Mansegal, who is our GP moderator. Danny is the principal GP at the North Road Medical Clinic in South Caulfield. He's also actively involved in the Cabrini Rehabilitation Program, and he has a strong interest in musculoskeletal medicine, men's health and travel health. And I'll invite Danny to just come up now and give us a bit of an overview as to his views on shoulders before we start with the cases.
Good evening, everyone. Just a few quick comments, really from the GP perspective. Shoulder pain is the third most common musculoskeletal presentation in general practice, and annually 1 to 3% of the populations are likely to consult with their GPs with respect to new shoulder pain. So as GPs, we should be able to get a good idea based on history and physical examination what our provisional diagnosis should be, and if the findings are ambiguous or equivocal, what the differential diagnosis should be. And we need that information to decide if and what sort of imaging should be done to aid in our management decisions regarding appropriate referrals to physiotherapists, focal injections that we may wish to organise, specialty review, and or any medications that we may wish to start up on. So today's evening takes us through some of the common scenarios and help us upskill regarding what to ask for and to look for when we're seeing our patients, and the sort of imaging that we should be organising based on those clinical findings. So I'd like to thank Andrew and Victoria House and the talented team who have come to help us out tonight, Stuart Down and Austin and Nick. And without further ado, I think we'll get going.
Okay. Just a few little extra bits of housekeeping. I'll get you all to turn your mobile phones to silent so we're not distracted during the talk. Also, there are toilets just down the corridor there, just before going up the stairs. There are toilets just behind the grey wall there, and Tony's there. He can also direct you there as well. Okay, so let's begin. So I'm just going to give you a very quick overview to the radiology around the shoulder, in that there are sort of 6 different modalities or options available to us, and we will discuss some of those modalities in the cases that we discuss tonight. So firstly, X-ray. X-ray is very important. X-ray is often forgotten. We all get excited by MRI and other high-tech imaging, but X-ray is crucial to give an overview as to what is happening with the shoulder. We get to see the alignment of the glenohumeral joint. We're able to look at the AC joint. We're able to see soft tissue calcification, and we can also see if there's underlying degenerative change. So X-ray is important and shouldn't be forgotten. Ultrasound is a crucial modality in the shoulder. It's very dynamic. We're able to put the patient's shoulders into different positions to optimise imaging of the different tendons. We're also able to assess the bursa, see if the bursa is bunching. We also get the ability to talk to the patient to work out where their pain is and scan these areas of tenderness. MRI, I think, is more an overview modality. So if patients are young, if we're concerned about instability, then we should do MRI to assess for a labral tear. MRI is the only modality that can see the labrum. It also gives us excellent vision of articular cartilage and other structures. CT is more specialised. It's really used for detecting occult fractures, characterising a fracture for surgery. We also do specialised CT here, looking in patients with chronic instability to assess how much bone loss there is on the glenoid, so whether or not the patient should go for a arthroscopic repair or maybe consider what's called a Latarjet, which we can discuss more in the cases. We can also do dynamic CT, 4D CT, which is looking for movement, looking for impingement or areas of instability at certain joints. Nuclear medicine is very exciting, and I spoke to some of you as we went round, is that it gives us the ability now with CT SPECT to show functional activity. So you can see on these very small images these areas of increased uptake which are red, and then we're able to put it onto the CT to give anatomic correlations. But again, it's very specialised, but we may use it for loosening or infection of prostheses. For guiding intervention, we've just got a late visitor, but we're going to direct them down to the side for Julie or Tony. For intervention, we tend to use ultrasound to guide that. It's the best modality, so we can put a needle into the bursa and put fluid into the bursa here. We can also inject into tendons or AC joint. If we're injecting the joint, we will use X-ray guidance for a shoulder hydrodilatation. So we'll move on to case 1. Case 1 is Lachlan, who's a 17-year-old student. He had a skiing injury on the weekend. He fell onto his left arm and heard a clunk. He had acute shoulder pain. His shoulder has remained painful since. However, he can move it in all directions with some discomfort. He comes and sees you on Thursday morning. So I'll now ask these questions of our panel, and we'll start with Stuart, our sports physician. Given that history, what are some of the possible causes of Lachlan's shoulder pain?
I think in the young age group, participating in sports like skiing or football or other ball sports where they've described quite clearly a clunk, in that age group probably the top of the differentials would be glenohumeral instability, a dislocation or subluxation episode, other things that might be considered as fractures around the shoulder joint. So it could be a clavicle fracture, outer third clavicle fracture in particular, or possibly other dislocations such as AC joint dislocation. And then probably less common might be something such as simply a contusional impingement. So someone that's just had subacromial impingement and the clunk has maybe been some usual movement within the shoulder just from the fall itself without dislocating or breaking anything.
Okay, very good. Are there any specific questions that you would ask for more in the history?
I think based on the highest likely differential being instability, key things that I'd probably ask is whether Lachlan had experienced dead arm symptoms. And dead arm symptoms, really we're talking about, I suppose, a neuroplaxia or a stunning of the nerves, typically the axillary nerve. And the patients will often describe their arm as feeling like it's just gone a bit clumsy or a bit dead or tingly or numb or heavy. And that can last anything from a few seconds to, even up to half an hour to an hour or so. I'd ask them if they can recall any specific deformity or steps, which is probably going to be hard for a skier because they're going to be heavily clothed and not being able to see things as you might do with a footballer. But certainly when they got back to the medical centre or their room or whatever, I'd asked about, steps, deformity, swelling, any localised swelling, and probably whereabouts they felt the pain immediately. The AC joints typically will be very localised. They'll usually point right on the AC joint, as opposed to most of the other pathologies that'll be typically a bit more generalised. And then probably the other thing is really just asking if they had a history of instability before, if they had a subluxation or dislocation episode previously.
Okay, very good. Austin, do you have anything you want to add on the history?
No, I think Stuart covered it pretty well. The other question, apart from the mechanism and what have you, apart from pain, do they have any clicking episodes? We're thinking, is it possibly other labral pathology, like a slap tear? And I guess skiing, you can get any fractures, but other less likely things, you may think about scapular fractures or glenoid fractures. So they're the other things.
Sure. Okay. What specific physical examination findings would you look for? So I might even invite you to stand up with
David, wasn't it?
Yeah. And we'll go through how you would examine someone in this clinical setting.
Yeah, absolutely. So nothing's changed since medical school. So we start very broadly first, look, feel, move. And generally I would undress David from the top down. But we'll leave him dressed for the purpose of this and video going as well. But so on inspections, and thinking about the three possible top causes that Stuart mentioned, AC joint, you mentioned clavicle fractures, as well as instability. So on inspection, you look for the obvious deformity. Is there a step over the clavicle, or the AC joint, and then make sure you look at the back as well, and then movement. So testing for active versus passive movement. But when you think about, so once you focus more on a specific diagnosis such as instability, then I want to probably do an instability exam. And that starts with two positions. One with David standing up, so I might assess for if he's had a recurrent issue of dislocation, I'll assess for socket sign. So what I'll do is pull down on his arm and look for any dimpling just underneath the acromion, and that's sort of more is akin with multidirectional instability. Then I do my apprehension relocation test, and in this instance I'll probably get David to lie down, but we have a bed here, so you can do it standing up as well. But I find with the patient lying down, you're much more controlled. So I keep going this way.
That's okay. You can bring David this way,
David,
actually.
Come
a bit more.
So
keep coming.
The adductive sort of rotated position, and with the sort of forward force, and you look at the patient's face, and certainly you want to warn the patient first, and you say you certainly don't want to dislocate the shoulder, but looking for any signs of apprehension, he'll probably stop you there. So that's a positive apprehension sign if the patient feels apprehensive or tells you to stop. And then you can confirm that with a relocation test. So in that position there, with a proceed-directed force, and I'd ask David, does that feel better? And generally they would say, yeah, it feels more stable. So that's a apprehension relocation test, so for instability. Last but not least, if you think about instability, you want to make sure you don't miss someone who's got ligament laxity. So very quick screening tool, you can do in 10 seconds. I call it the Wynne-Davies signs or baby score, and you can quickly assess it. So I asked David, could you bring your thumb parallel to your forearm, in the position there? So you can't do that. Hyperextend the middle finger or MCP joint. So that's 2. And third, I test for elbow hyperextension. So he doesn't have that. And then you stand facing that way, and then push your knee all the way back, so looking for knee hyperextension. And last but not least, bring your feet together. Can you touch the floor with the palm of your hand? So So he's 0 out of 5, so he's definitely failed all that. But if you get 3 out of 5, then you've got someone who's got generalised luminous laxity. So thanks, David.
Yeah, no worries, you can come back.
Anything else?
Oh, I think going on my anticipation of this being instability, the other thing I'd add on would just be testing the sergeant's patch, auxiliary nerve sensory distribution. So-called sergeant's patch, people in the military having their badges, upper deltoid, and that would heighten my suspicion of instability, but less likely to be present 4 days down the line, but something to consider.
Okay, very good. Okay, thank you. Okay, so back to Stuart. What investigations would you consider?
I think, as Andrew reiterated at the start, we often forget this simple thing called an X-ray, and I think in the setting of any acute trauma, myself for shoulders and knees and ankles and hips probably for that matter, routinely start with X-rays. I think that we're blessed having people like Victoria House, so we don't need to remind how to do the X-rays, but if you're using some of your peripheral sensors, and it's always worthwhile to ask for an instability series of X-rays, so specific set of X-rays that are designated to try and show the pathology that we see in instability, as opposed to an impingement series, being a little bit more different and focusing more on rotator cuff pathology. But certainly I'd start with plain film X-rays to assess for bony damage of the inferior glenoid, Hill-Sachs lesion of the humeral head, which we'll come to I think a bit later. And over and above that, I probably would go MRI as well. So, if this comes into my room, I'll usually ask for both X-ray and MRI because I think they've both got their advantageous information.
Okay, so and we've sort of covered some of the so. As far as advantages, disadvantages, we wouldn't go to ultrasound because ultrasound is not going to be able to assess the labrum. X-ray, as Stuart has pointed out, we do have the instability series, so we have particular views called the West Point and the Garth view, which are designed to better show Hill-Sachs lesions and also the anteroinferior margin of the glenoid to look for the bony Bankart fracture. So here is an X-ray. Set of X-rays, and we can see obviously on this internal view, AP internal, we can see this Hill-Sachs lesion. So we can see here concavity in the humeral head, greater tuberosity junction. We would also inspect the anteroinferior glenoid once we see the Hill-Sachs lesion to see whether or not there is a bony Bankart lesion. The other fractures which can sometimes be associated is a coracoid process fracture as well. We then went to MRI as well. So here is an MRI. This is a proton density fat saturated sequence. So this sequence is designed, we're looking for white on a black background. So we make the fat in the subcutaneous tissues and in the bone marrow. We suppress that fat away because fat is bright on proton density, but by suppressing the fat away, then the bone contusion where the trauma to the bone has been stands out. So we can see bone contusion, we can see the Hill-Sachs lesion, we can also see the joint effusion. We can also inspect the labrum. So here is the glenoid, here's the glenoid cortical surface, here's the posterior labrum which is intact, but anteriorly we can see joint fluid undermining the labrum here, so this is a labral tear. And we can also see the cartilage. So the cartilage is this grey component here of the glenoid, and as we come across here we're seeing we're missing articular cartilage here as well. So this injury has injured the labrum and the articular cartilage. If you imagine that the humeral head is sort of going across in this direction, shearing across this portion of the glenoid, it can involve bone and produce a bony Bankart fracture. It can involve the cartilage, it can involve the periosteum, involve the labrum. So we sort of describe the injury, describe what's happening to then help the sports physician and the surgeon to sort of grade the injury, know what they are dealing with. If I just quickly touch on MRI safety, you guys are our first line of defence. The MRI machine is always on. So on our referrals, there are basic questions there to try to screen out people who are not safe for MRI, such as aneurysm clips or pacemakers. We ask many times about the contraindications, so you guys are the first line of defence. Then our reception staff will ask the patients questions to screen out people. And then When you arrive for the scan, our technologists, so Eddie and Jack, will also ask the patient and they will fill in a questionnaire. If a patient does have a device inside them, what we do is that we check that to a reference. There are some devices that are safe at, say, a lower field strength magnet, such as 1.5 Tesla. We have 3 Tesla here because we get better image quality, but we could send them to another MRI in the MIA IMED network. We often get asked about joint replacements, so they are safe. So once metal fixation is incorporated after 6 weeks, these patients are safe for MRI. And here's a list of some of the contraindications. So things that are going to be displaced by the magnetic field, or things that are electronic, which are going to be destroyed by the magnetic field. And just to show you how strong the magnet is, here is an overzealous patient. The orderly was very keen to help and wheeled the trolley into the MRI room, and you can see the power of the machine, that it was able to suck the trolley into the bore of the MRI, and so the patient needed an MRI also of their cervical spine. But if we talk about dislocations, I might.
So look, far and away, the most common is anterior dislocation, anterior and anterior inferior combined. And they are typically, as Austin demonstrated in that apprehension position, what we call an ABA, so abducted, externally rotated, or stick 'em up position. And that's often, in particular the footballers that are going for mark and they get a knock, and they get heavily thrown backwards into horizontal extension or fall onto the outstretched hand, as was the case, or probably the case in this one, is also a fairly common mechanism. The posterior are much less common. We probably don't pick them, I'll confess, I don't pick them as well as I probably should, and I think they can sometimes be difficult, but they tend to be a little bit more of a direct blow to the front of the shoulder, forcing out backwards, or some texts talk about falling in a position of internal rotation and driving out the back. And then I've included the 3As just, I suppose, for something of interest, thinking of patients that have either been electrocuted or epileptic or under the influence of ethanol, are probably perhaps more predisposed to posterior instability. And then inferior, pure inferior, I don't know whether Austin will agree, probably hands down the least common, and tends to be more of a traction injury. So the grappling sports that we might deal with, wrestling or judo or mixed martial arts.
Okay.
Andrew mentioned the instability series, and you talked about posterior, sometimes often missed. You can be tricked on an AP X-ray, and Andrew probably alluded to this, because often their arms in an internal rotated position, and the humeral head actually looks like it's aligned with the glenoid, but there's a name for what they call a light bulb sign, where it looks symmetrical. So you do have to ask for additional view, like a axillary lateral view, to see whether it's a posterior dislocation, because that's often one of the things that's missed.
Good point. Okay, and then if we just talk about some of the associated injuries with dislocation.
Yeah, look, I won't go into great length at this. I think we've already touched on some of them. A lot of injuries, in particular the traumatic dislocations, as opposed to people with underlying multi-instability or hyperlaxity syndrome. The acute traumatic injuries often are associated with, I suppose, technically what have to be called fractures, even though we don't really consider them as such when it's a Hill-Sachs lesion or a bony Bankart, which are more impaction type injuries, and more often than not don't really require specific fracture treatment, save for the big bony Bankart. But probably more so in the older age group. Again, I'll invite Austin if he wants to add to this, but the older age group probably more at risk of having associated greater tuberosity avulsion fractures or rotator cuff tears. Pretty unlikely to see that in a 17-year-old. And then other fractures around the shoulder, so coracoid or humeral shaft. And I think I already mentioned earlier, axillary nerve is fairly common. What percentage would you say people have axillary nerve? Probably 10%, 20%, something like that. And then vascular injury, I've not come across myself, but it's said to be more the older age group.
Okay.
A couple of points, back to that slide, Andrew. So with Bankart lesions, and you can correct me if I'm wrong, but even after a single traumatic dislocation, as high as 90% will have a Bankart lesion. So on the flip side, if you think someone's dislocated their shoulder and you do an MRI scan and there's no Bankart tear, you got to think, is this really a traumatic event? Is it more subluxation or multi-directional instability. So, I always get an MRI scan, but almost 9 out of 10 would have a Bankart lesion if it's a true traumatic dislocation, even after one episode. And to what Stuart said about rotator cuff tears, that's very common, particularly in the sort of middle-aged or older patients. I can say old now, I'm over 40, but if you have someone over the age of 40, have a low threshold for getting an MRI scan, because these are the patients that often come to the emergency department. They've had their shoulder reduced, there's no fracture, and then it's very easy for us all to relax. But the studies have shown that 50% or more will have a rotator cuff tear. That's often an acute rotator cuff tear that you don't want to miss.
Okay.
I think one other final thing I'd say is as much as the scans are just continuing to get better and better, the MRI scans are not 100%. I've lost count of the number of times I've been in theatre as an assistant surgeon with upper limb surgeons, and you look at the scan and there's really not much to see, and they've got a significant labral tear. They are good, but they're not 100%. So first and foremost, back your clinical judgment, and if the history and the exam strongly supports instability, you're probably right.
Just to support MRI, sometimes we do what's called an MRI shoulder arthrogram. So the patient may have had a routine MRI, which is normal. The clinician is still concerned about labral pathology. We will inject contrast into the glenohumeral joint to sort of distend up things, and we will also scan the patient in that ABA position as well to put extra stress on the anteroinferior labral-ligamentous complex to try to show things being displaced. But we do that occasionally. But if we now shift to sort of the options regarding management of the shoulder dislocation, and I might sort of throw across the whole panel as well. Obviously, we can consider conservative management versus surgical management, and we might invite Nick as well to sort of get involved, but I'll let you take it.
Yeah, look, I think probably the single biggest determinant, or probably the biggest determinant for me, is age. I think that the statistics are pretty strong that if someone's had acute traumatic instability episode, probably confirmed on scans with bony Bankart and clinical signs of instability, if they're engaging in fairly high risk activities, in particular football, contact sports, skiing I probably would include. They're at age 17, I would probably quote in the rooms the likelihood of a recurrent instability in the next 5 years upwards of 90%. So I think when that age group goes out to probably a 35, 40-year-old, it's probably going to bomb right down to probably 40%, 30 or 40%.
Yeah, even less.
Even less. So for me, age is probably going to be a big determinant in how I manage it, whether it's something that I steer towards Nick for physio or whether I'm steering towards Austin for surgical intervention. But then I suppose, other risk stratification, asking what's their dominant hand, what they do for work if they're in a working age group, any other sports they're involved in, what their career aspirations are. And a 17-year-old, is he a draft pick, for example, which we know, the AFL people are going to be really wanting to make sure that he's a safe money expenditure if they're going to be picking him in the draft. I'll hand over.
If I jump in here, from a allied health perspective, I do a couple of things, and I'd like to show you some things from an examination perspective. So if we could jump up. So there's a couple of extra tests to go on top of the orthopaedic tests that I do. I'm lucky enough to work with some world experts up here at Paran regarding the shoulder for a number of years, and so some of the things they do, more so in the chronic dislocations or MDIs, is humeral head correction. So the special tests haven't changed. So you could do, even just active range of motion. So we're trying to work out whether, from my perspective, whether it needs to go to Stu or Austin, or for imaging. And I often don't send for imaging. I'm sort of more sending back to Stu for imaging and things like that. But correction-based techniques, so your humeral head, so we can simply apply, let's say, it was Dave, wasn't it? Yeah. Dave, so if you lift your arm forward and it's sort of pain about there, I can try things like, so we're thinking anterior dislocation, I can glide that humeral head backwards, then I get you to move forward with me, mate. And then go there, and then you say you go on, so let's assume that you go further right, so I go right, beautiful. So that there is a good sign that say, I've got to work out whether it's a green light, orange light, or red light. Orange light being I go to Stu, not sure, imaging. Green light, maybe we trial 6 to 12 weeks of rehab. Red light, it's not going to work. Rehab's not going to work. There's, a decent lesion, and it's maybe going to Austin sooner or later. Other sort of things we might do is sort of scapulothoracic corrections. So We come up under the arm here, and it may be more sort of for impingement, so it's coming through here, and I do sort of most commonly an upward rotation, so you relax more relax. As me doing, you've got to get personal with your patient, and you're lifting up here and then getting them to abduct, and it often clears their pain. Often that, or maybe even say upward rotation to tilt posteriorly, so it tends to increase the subacromial space. Even that, and combined with a AP or a block posteriorly for those posterior instabilities. Sometimes it's just as simple as putting my thumb in the back of the joint, getting them to do that, and they go, oh, it's like you're a new man. They need, they're getting an actual, posterior translation. So that's some extra tips I sort of do from an allied quick GP assessment to try and sort of work out where we're going from rehab through to orthopedics or physicians.
Let's say we've gone now, we've trialled a sort of conservative approach, and the patient's having recurrent subluxation events, or they're very young and want to go back to sport. If we go to the surgical approach.
Yeah, absolutely. So in terms of determining which patients need surgery, like Stuart said, it's based on natural history. That's on age, risk factors, and also we talk about imaging, so what the pathology is, whether it's just soft tissue, which is the most common, or is it a glenoid fracture, or rotated cuff, or great tuberosity fracture. But say in this instance, you've got a 17-year-old dislocates their shoulder for the first time, and say he doesn't, he's just a skier, he's a young kid, doesn't play any contact sports. I would try rehab first. If that's failed, then based on the MRI scan, if it's just a Bankart tear, then I'd do a soft tissue reconstruction, so Bankart repair, which is what we call the traditional anatomic repair. If, say, he's right-hand dominant, it's his right shoulder, and he plays collision-type sports, typically AFL, then you've got to look at, what's the risk of redislocation with just a soft tissue procedure. And there's enough evidence out there now that's leaning towards more of a bony procedure, because soft tissue repair, has a 3 or 4 times higher failure rate in this sort of population group. So it's based on, the type of patient, the natural history, and then there's pathological sort of threshold. So if you've got someone who's got a recurrent dislocation and they've got bony loss, so we talk about X-ray first and foremost, MRI scan. For most of my patients, once I'm determining whether they need surgery or not, I'll definitely send them for a CT scan, just to more accurately assess the amount of glenoid bone loss. And Vic House do very nice imaging in terms of 3 and 4D reconstructions, humeral subtraction, and you can measure out the amount of glenoid bone loss compared to the other side and determine based on that whether someone needs more than just a soft tissue reconstruction. And Andrew did mention the Large procedure, which is what we're referring to, a bone block operation. So it's based on all those factors.
Yep. Okay, very good. Any
Got a question over there?
So what sort of timeline? Say that person 17 wants to ski continuously, so you're thinking a surgical one. How long would you wait before you go in? And you have to wait for swelling to go down, or?
I'll just try to summarise and repeat the question for the video. But the question is sort of what sort of timeline would you wait before you try surgery? How long do you have to wait for swelling and other things to go down? What's the timeline from conservative to surgery?
Yeah, with acute shoulder dislocation, there isn't really a set time frame. It's not like an ACL where you need all the information settled down. Otherwise, if you do the ACL reconstruction, they get stiff. It's different with the shoulder. But in this particular patient you're referring to, I wouldn't rush into surgery. I'd just send them to Nick and start them mobilising their shoulder, get the swelling down, test their strength, and see if they have symptoms of instability. Because even though if you look at the stats, the risks are high, I think there's enough evidence support, seeing how they go with non-operative treatment initially. And if they have a second dislocation, then you probably have to have a chat. So it's pretty controversial if he doesn't play collision type sports, to do a reconstruction straight away. That's completely different to someone who does play collision sports. So for those patients, then they usually get an operation earlier.
Okay. We'll take any other questions on this particular case. Okay, so yep.
Sorry, probably said and understood, but if they do go ahead with surgery, what's the time frame for recovery?
Okay, so I'll just repeat the question.
Rehab.
So if the patient has surgery, what's the sort of timeline for recovery, including rehab, maybe for you and Nick.
Yeah, probably. Nick, you can.
Well, I guess it's definitely dependent on outcome measures. So, I would use something like this, something like this, because you don't know what's going on. You got to measure things to create outcome measures. So this is a little dynamometer. So we would measure strength, and often do strength tests based on sort of somewhere between sort of 4 to 6 months post-op in the normal population, rather than say the elite athlete. It's a totally different game. And take outcome measures. So we use this side, for example, we've got to know all these things. He's going back skiing, so he's not an overhead athlete. So if we've got good strength from sort of, comparatively, so ER through here, extension here, because skiing is just in here, an internal rotation, then, that essentially is the score we're looking for. And that was comparative to the other side with good scapula and good humeral head control, then I'd be happy for him to return at that point. So there's no real time frames on these things have really changed for me. I don't work with time, I work with objective outcomes.
For an athlete?
Yeah, absolutely.
Or an
Yeah.
athlete, yeah.
So I guess the other part of your question is, patients want to know, when can I return back to play sport? And that's what they ask. That's what they want. So in terms of return to sports, depends on the healing, and there's no real way we can speed it up. So we know with a soft tissue repair, like a Bankard repair, arthroscopic, they still take 6 months to heal, best case scenario. Whereas if you do a bony procedure, like a Radiology procedure, basically where we take a bone block from the coracoid, fix it to the anterior aspect of the glenoid, that's bone fixation. So you get more reliable union of that, and you can assess that on a CT scan much easier. So for those patients, I halve that. So for them, I quote 3 or 4 months in terms of return to play, which makes a big difference. And that's sort of the game changer, particularly for elite athletes who want to return in season, or particularly, when I worked overseas, often they want to come back mid-season. So a lot of their trainers are sort of pushing towards having a larger procedure just because they can return early to sport.
Okay, very good.